right, Tarun? Very good for our, as I said, with simultaneous case, we are going to show sequential, actually, not simultaneous. And only change is our fellow here, Penta, which, as I mentioned, we have 3 structural fellows. And let's start show the slideshow, case number 4.
Show the slides, please.
Slideshow. So it will be a Redo-TAVR for degenerated TAV with HALT using Evolut FX. So in this particular case, this is a little 10-year younger than the previous patient, 82-year-old, has dyspnea, syncopal episode, has a TAVR in 20. So actually, and then using Sapien Ultra at that time, and we'll go through that why this happened. Multiple comorbid condition, extensive peripheral arterial disease, even carotid endarterectomies and so. Patient, as I mentioned, that had the valve about 4 or 5 years ago, 4+, and now presented with syncopal episode. And clearly the good medical therapy, and she has a PCI of the vessel. So this is where we have the TTE, and now this is the recorded one, and we'll show the live echo by Stem Larakis. Stem?
Yes, thank you. Thank you.
Go to the live, please. Live echo.
It's on?
No, wait 1 second. Okay, live echo, please.
Drop down. Sorry, okay.
Yeah, okay.
Yes,
yours.
So as you can see, severely dilated left ventricle, ejection fraction about 30 to 35%.
Sam, a little louder.
No pericardial effusion. Moderate dilated right ventricle with decreased function.
Wow.
Moderate tricuspid regurgitation. PA pressure about 40, mild pulmonary hypertension. Mid-esophageal images, as you can see, the chamber left ventricle dilated, the right ventricle dilated, retracted posterior mitral leaflet. Bicommissural view showing the about moderate to severe MR with thickened leaflets. Sapien valve, as you can see, explain thickened calcified leaflets, decreased excursion. About moderate valvular AI, central AI, eccentric jet. Pressure, vena contracta of 0.6, consistent with moderate valvular AR, and this is deep gastric images explained through the valve. Again, very important to use the explain to make sure that the AR in this case is valvular and not paravalvular, and this is the best view to figure out that. Pressure half time about 3/10, so moderate AI, valvular AI. Peak rated about 2.9, velocity 2.9, peak rated of 33, mean rated 20, aortic valve area 0.7 centimeters square. So it's a low flow, low gradient aortic stenosis with a stroke volume index of 22. So it's a degenerated Sapien valve with both AS and moderate AI. Thank you.
Beautiful. Okay, let's go to our presentation now. So therefore, what is your feeling now? What is the mechanism of this AS and AI? It is the regurgitation more or stenosis more or combination of both? Compared to the previous case, was like 90+% was stenosis, and that was 8 years. This is about 4 years, and now we are seeing this both the AS and AI combination.
Probably a combination here. You can see the hemodynamic tracing. You know, I think luckily the pigtail just dropped into the LV, so we just took some hemodynamic tracings, and you can see how there's more AI than AS, but definitely HALT and degeneration can present in regurgitation, not just stenosis. So I think it's mixed valve disease at this point.
So this is the pre-TAVR CTA. So
right.
First one, right?
Yes, that's right. So, because you can see that it's actually quite oversized, 16% oversized by the 23S3. So what happened, I think, here is that the valve was underexpanded, even though it was appropriately sized. Next slide. And you can see the generous root. Next slide. So here you can see that it was clearly not 23 in terms of inflow, midframe, and outflow. You can see it's well below that. There's a waste. You can see it on floor later when Sahil show you. Next slide.
Now, question comes in at time 0, knowing that we did this case here. So was it, should we have used a smaller valve and over-dilated, or what could we have done differently? Because 8 years is a good time. But you tell somebody you're coming back within 4 years, that you really get a big flake from the patient. You know, you told us 8 to 10 years, and now you're bringing us in within 4 years.
Sahil, what do you think? What would you do?
Yeah, no, I think SSV did everything appropriate. You know, these valves can recoil, unfortunately, and that causes pinwheeling of leaflets. And obviously, it's a nidus for degeneration and halt. I'm not sure we would have done anything different in terms of sizing. I think this was a straightforward 23 valve. What we could have done going forward is maybe do 2 inflations and make sure, you know, the second inflation really opens up the valve.
Yeah. I mean, the alternative obviously uses there's another like a tall valve, right, in terms of self-expanding valve to avoid that, but you just have to pre-impose. And if you use a smaller valve and overexpand, you run the risk of prosthesis-patient mismatch as well, right? So anyway, so you can see the CT one is a bit more favorable. The green line is where the top of the sapien leaflet will be pinned, and then you can see the coronary is actually at the same level on the left main. And you can see that for the right is actually higher, so the risk of coronary obstruction here, fortunately, will be lower than the previous one. Next slide. And so you can see that here, that's the HALT with the arrow. You can clearly see that on CT and on echo that Stan just showed you. So with the TAV in TAV app, you can see that here it's pretty clear in terms of we're going to put an Evolut in the sapien because of supraannular and hemodynamic benefit. So I think it should be pretty safe from a coronary obstruction standpoint. Next slide. Yeah. So here we should talk about the access though.
This is very horrendous access, unfortunately. So, you know, Redo-TAVRs can present you with a lot of challenges, and I'm sure everyone, Eberhard is there, Tarun's there, and they've all gone through this. So very calcified iliacs on both sides. The left ostial, as it goes into the aorta, was almost nothing. So I couldn't do any pigtail from that side. The pigtail is actually radial, and I had to do IVL and shockwave on the right side to get my access.
So you want to show that?
Let's show the fluoro, please.
Yeah, fluoro. So basically, this is what we are using 26 millimeter Evolut FX Plus. So show the, yeah, good. Yeah.
So I want to show this picture here, and you can see it's almost a 90% lesion on the left side as it joins the aorta. And the right side is reasonable, but again, it's around 5.2, 5.0. So I had to do IVL there. And once we did IVL, it was relatively easier. And you can see the expansion was expanded really nicely and put a sheath, and then we had no issues whatsoever.
Okay.
All right.
Now,
Actually, talk about the fluoro, actually, the angio here, Sahil.
Yeah, so the angio looks, you know, it's a well-seated valve. I think our coronary risk plane is very high up, so I'm not really concerned about, you know, any coronary issues during the procedure. But definitely, you see that dye staining in that leaflet, which is very interesting. Everyone talks about HALT in, you know, CT scans and echoes. I think there's some significance that the leaflet, the way it's staining all that dye, is not just sinus. I think there's some HALT there as well. So
yeah.
Just something to be cognizant of. Again, high risk of stroke in these cases, but unfortunately, I couldn't do anything because the radial was used for a pigtail here.
Okay.
All right. So where are we now? We're ready to.
Yeah, so it dropped in. So we
dropped in.
Yeah.
So valve went. That's good. Pigtail went in directly. Now you can use this.
So what? So any thoughts on the panel in terms of anything we would do differently? What's the strategy now for implant?
I mean, would you guys have?
This?
Hey, Gilbert, would you guys have considered doing pre-dilatation of the sapien valve?
Absolutely.
Yes.
Absolutely.
So Sahil can comment on that.
Absolutely. Whenever we are doing redo cases, have to pre-dilate and post-dilate. And especially in this case of a tall and short, I really want to make sure the short frame is optimally expanded before we put our tall frame, because if you don't do that, your post-dilatation, you don't get good results.
And what size balloon are you using?
23.
Yeah, good question. So it depends on the native anatomy. That's why the pre-index TAVR CT is so important.
Pre-dilate.
What balloon? What true balloon we have? 23. Yeah. So we were debating 22 versus 23.
Yeah, a little aggressive.
Think that, you know,
I would say.
Yeah, we're a little bit more aggressive. There's a risk of rupture, obviously, but we don't see on the pre-TAVR CT having any calcified anatomy. So we're going to see how it looks and behaves. But one thing is that, you know, if you don't do that with the leaflets thickened, you're going to underexpand the tall valve. And what happens is that you're going to have to post-dilate, but if you implant the valve too high, you won't be able to do that because you risk a pop-out. So we like to kind of precondition the first valve as much as possible.
180.
Maybe, Sahil, just a quick question. I understand why you can't use cerebral protection, obviously vascular access. But in terms of when you discuss this with a patient and the fact that you do have HALT there,
120.
you have to pre-dilate. How do you discuss that with a patient? Like maybe we'll talk on the
180.
panel, they're working, but how do we explain that to the patient in terms of risk of stroke? And that's a really important discussion to have. You know, Renu, what are your thoughts?
Yeah, no, I mean, I think that that's something that sort of worries me as well, right? I mean, the higher risk of stroke in these TAV and TAV procedures. And I think it's something that you have to really talk to the patient about and make them aware of. Because in this age group, that is huge to have a stroke, right? So you've gone through the original TAVR and now you are looking at a second procedure. It's huge. What do you think?
No, I absolutely agree with that. I think it's not very popular in these days to talk about protection, but that doesn't mean it's out. And particularly, you know, in high-risk groups like this, I think it's a very well-taken point that you brought up here.
I think the question is,
You know, the only thing, you know, we are, so, you know, you must be smiling. You know, we're trying to correct the surgeons and trying, why are you using these small valves? And now we try to break, and now we're correcting our own mistakes now, you know, post-dilated previously under-deployed valve. So I think the lesson that we need to convey to ourselves, actually, try to do it as much, you know, the initial expansion really is very important.
you know, we've learned that from the accurate data also, where under-expanded valves had worse outcomes. But I think the key is, can we assess expansion fluoroscopically when we do this procedure and optimize the expansion at the same time before taking this patient off the table?
Well, I think that's a very important point because the gradients are not going to tell you whether the valve is underexpanded, right?
Yeah.
That's the lesson to learn.
Because we are post-dilate for gradients or PVL, but to achieve optimal frame expansion, it's a new thought, and it has translated into valve durability or outcomes, at least in these small studies.
Phase 150.
You want to start here? You want to start higher?
Start here.
Yeah. So we're diving.
Yeah,
I
I'll
mean,
answer
other
all your
than going
questions in
into
2 minutes.
the two views or
wire.
using TE, I don't know how else we can assess frame expansion, right? We're going to have to do the two views.
Right.
Most of us are not doing these cases under GA with TE. We're very minimalistic now, so we can get patients in and out. So I think at the very least, we need to go two views and make sure we have that frame expansion.
Yeah.
Recapture.
Sahil, are you guys going inflow to inflow on the position?
We're trying to land it in inflow to inflow.
150. We're trying, but you know, because the sizing mismatch is going to be push the
Yeah,
wire
it's gonna
up. We
push
need
it
to really
down,
Push
yeah.
the outer curve.
No, get
Good.
the orientation right.
Yeah. Push the outer curve, please. Outer curve. Good.
Try here.
Okay, try here. Yeah, a little higher. 150. Yeah. Push.
Just stay
Maintain
here.
the wire. Maintain the wire.
Maintain, yeah.
Push the wire a little bit. Push the wire a little bit. Good.
That's actually
That's a little bit better.
Yeah,
Good.
much better.
Okay, 100.
100.
Try it. We're closing. Let me close it. Oh,
Good. Let's
okay.
get the blood pressure up.
Okay,
Okay,
blood-
this should release. We should deploy.
Remember the EF is low.
Yeah. Okay, let's go. Okay, we're gonna deploy. Okay,
We're
guys.
gonna deploy.
Go.
Okay,
Go ahead.
150.
No need to.
Yeah.
Blood pressure is low.
Valve is fully deployed.
Yeah.
Fully functional.
120. Watch. Yeah. Yeah. Good. Careful.
Pull the nose cone. Push the wire now.
Push the one. Back up now. Back up.
Good. Back up now.
Okay.
Thank you.
Resuscitate, please. Ben.
Very good.
Okay. Let me remarry.
Let's remarry.
Okay.
Okay, it looks very good.
We should post, right?
Pulse it. Yeah.
We're gonna post this.
Pulse it.
Yeah. Let's take it
No
up.
PVL,
Very good. I'm gonna
Okay, come
post
up.
dilate this.
no valvular.
Same balloon.
The valves.
Give me the 23 balloon again.
Pressure is coming up. Excellent. So you can see the valve tends to die because of this mismatch in sizing, 26 and a 23.
Okay, take it.
So that's why we like to push the wire to the outer curve, but unfortunately it was not responsive.
Push the
So you have to start maybe like just above the inflow because when it flowers, the FX platform is more symmetric. But if you don't have the wire to the outer curve, it's going to go deeper on one side. You saw that earlier. You just dive deeper.
Okay,
So the
coronary
trick is to
position.
actually start a little bit above, and then we'll lock in. And once it's locked in, you don't worry about pop out because it's locked in, and so you just have to release.
Coronary flow sheet.
And obviously, you have to look at the patient's hemodynamics to make all those decisions.
Okay.
Any comments? Sorry, there was a lot of discussion among the panel, so we're focusing on the
Color off.
implant, but we can talk more now while they're
You know,
ready to post dilate.
We used a 26 Evolut in a 23 Sapien, and in the previous case, you put a 23 Sapien and a 29 Evolut. So which is what we do, right? We downsize one step, one valve size, when we do a Sapien and Evolut, but we upsize appropriately to the native annular sizing, index TAVR CT, when we do an Evolut inside a Sapien.
Would anyone have considered a repeat sapien in this one? What would you guys have done,
That's a good question.
right?
Well, unfortunately, I think a repeat sapien would be a 20 And I
Yeah.
think that's what the
Right.
concern would
Yeah.
be. If the repeat sapien's 26, I
Keep
think that's a
pacing,
different
keep
story.
pacing, keep pacing, keep
So
pacing, keep pacing, keep
we-
pacing.
Off.
We would do a
Keep
repeat
the wire in.
sapien, but it would be a 23. And we've done a few. You put a 23 sapien and then you post-dilate with a true balloon. We feel with the two valve frames, the radial strength may prevent post-dilation, but it actually responds pretty well. So you can put a 23 sapien 3 and then take a 23 true balloon and really stretch it. We actually did a live case to one of the conferences a few months ago with that strategy.
I think it all boils down to hemodynamics, right? So how you perceive hemodynamics, what you want for the patient. This patient
Okay,
already has a
Jose.
low EF to begin with.
Let's go
Last thing I
fast.
want to leave is
Put some
the mean gradient more than 10, and I totally
Yeah,
understand. And that was one of the reasonings we said, you know what,
the
let's
wire
use
is
an
in.
Evolut, gives you better hemodynamics in these cases. So
Okay,
again, very
Ready?
patient-specific
No, but make it in the center, bro.
decision-making.
There, yeah.
And Tarun, to your point, I think you also need to individualize the patient's, need, and I think that's why the value. And Hassan Jalhawi, your partner, is a believer of this to get the pre-TAVR CT, pre-index TAVR CT. Look at the lay of land because we all know anecdotally that patient have ruptured because they were too aggressive with the pre-dilate to put the second balloon expandable valve. So to your point, that I think you need to, look at the patients across time to try to really understand the anatomy before just a blanket saying that for every patient would do it the same way.
Here are the
Absolutely.
gradients. Can we see the hemodynamic screen, please?
It's there. It's being
Okay.
shown. No, they can see it.
And then Stam can comment on the echo afterwards.
Yeah, mean gradient of 3.
And the EF kicks
PVF?
back a little bit.
Yes.
Good. EF change?
EF is about the same. 35%. From 30 to 35.
2 points improve.
Beautiful case.
Yeah, take that, prof.
Should we do an aortogram?
Big
We didn't do
gradient?
one
Sure,
yet.
yeah.
Yeah.
Dr. Sharma loves aortograms.
Yeah.
That's right.
Why we want to?
Can I just
Please,
question
Stam.
the valve choice?
Yes. Of course, Eberhard. Please.
No, I'm just questioning
please.
a sapien and sapien.
more.
Would that be
PE up.
would that be an alternative? I know that they took the effects because of supraannular, whatever that means, but would sapien and sapien be an option?
In my opinion, it would be, but again, I think you can't argue with success, and they have a beautiful result. Would the open cells of FX help in this case? Because those are hidden behind the sapien frame.
Yeah.
The result is amazing.
No, I mean, we don't argue good results, obviously, but you have to make a decision before you know the results. So my question was...
I think you could do it with sapien
Is this
also.
the main reason for being supraannular?
I'd be concerned with sapien and sapien just because the first sapien failed in 4 years. There was a reason, and it could be undersizing, right?
Right.
But you could end up with the same issue. So I actually support the decision.
Yeah, good point.
Yeah.
I think the real question is, what would be your pharmacotherapy now, post-TAVR? Because the underlying mechanism, at least in this case, was HALT. This patient is 82 years old, so would you keep this patient on anticoagulation lifelong or a few months or no anticoagulation at all?
I think that's a great point, because if you look at
this
that
case,
AI, it looks like that leaflet is being held open by that thrombus. And so,
And with
you know,
all the
you'd
dysfunction.
want to keep them on anticoagulation. I think you have to balance it with the individual patient's risk of bleeding and have that conversation. And these are all conversations you need to have before, I think, to discuss that.
I think you also have to see how the LV function improves, if it does improve post.
I think he said she already has atrial fib, so she has an indication for
Yeah.
anticoagulation.
Indication for, already was on apixaban.
See the
So now with that note, I think we finished way before time. Why can't we have a quick 45 minutes, 50 minutes lunch break? And then we reconvene
We
at
wouldn't expect
1:40?
anything.
What do you think?
Explain.
Huh?
Perfect.
At
Okay.
1:40. Yeah, we reconvene at, great job.
Reconvene at 1:40.
Thank you. Beautiful cases.